So today here I'm going to discuss about the receptor pharmacology. So the receptor pharmacology that is coming under fourth semester B Pharm pharmacology. That means pharmacology 1. So upon studying this receptor pharmacology, it is an open integrated within pharmacology 2 and advanced pharmacology. So it aims to provide students with a deep understanding of how the drugs interact with the biological system at the molecular level. So upon studying this receptor pharmacology, upon completion, the students are expected to achieve the understand the receptor classification. That means the major classification of the receptors, including G protein coupled receptors, intracellular nuclear receptor, and they will should know to explain the signal transduction pathway, describe the molecular mechanism by which the receptors translate binding event into the cellular responses, and they must know about the secondary messenger system, CAMB, DAG, calcium, etc. And they should know about the analyze the drug receptor interaction. That means they evaluate the fundamental principle for the receptor theory, such as affinity, intrinsic activity, agonistic activity, antagonistic activity, etc. Inverse of gods, etc. And also understand the quantitative pharmacology, interpret the dose response curve, DRC curve, and calculate the parameters such as antagonistic affinity, agonistic potency, and from the experimental data. And also, upon completion, or the course outcome of this particular topic, receptor pharmacology is they will correlate the pharmacology with the disease. This is therapy. Explain, that means explain the mechanism of the drug action for various agents acting on the receptor in autonomic nervous system, central nervous system, cardiovascular system to treat the disease. And they should be able to demonstrate the laboratory skills, such as they conducted similar experiment using XPAM or isolated tissue preparations, etc. And ability to interpret the in vivo and in vitro drug effect on the biological tissues, and proficiency in using the software models to predict the receptor interactions. So the term receptor, it is used in the pharmacology to denote a class of cellular marker macromolecules who are concerned specifically and directly with the chemical signaling between the and affinity means the capability of the drug to form the complex receptor complex with its receptor. That means a drug love to bind to a receptor for complement. Affinity means ability of the drug to binding to the receptor. Intrinsic activity means the ability of the drug to trigger the pharmacological action. That means to produce a response that will bind to the receptor, but moreover that will produce a specific kind of a pharmacological action. So D plus R leads forms to a DR, that is a drug receptor complex. D means a drug or a endogenous ligand. R means receptor. DR is a drug receptor complex. Yes. So next we can discuss the lock and key model of a ligand receptor interactions. So here the lock and key model of ligand receptor interaction. That means lock and key model explains how a ligand, that means a drug or hormone or kind of a neurotransmitter that bind to a receptor. So in this model, ligand means it is equal to key. Receptor means it is equal to lock. Ligand is a key and receptor means a lock. So only a ligand with the shape, correct size, and chemical properties can bind to a specific receptor and produce an effect. So lock and key model means a ligand means a key and a receptor means a lock. So only a ligand with the correct shape, size, and chemical properties can bind to a specific receptor and they can produce an effect. So the basic terms included in this lock and key model is a ligand and a molecule that binds to a receptor. For example, hormones like insulin, adrenaline, etc. Neurotransmitters like acetylcholine, dopamine, etc. Receptor means a protein located on the cell membrane. Firstly, we explain what is receptor. So the receptor means a protein molecule that present on the cell membrane, cytoplasm, nucleus, etc. So it recognizes specific ligands and trigger a biological response. That is the lock and key model. So the principles of lock and key model here, just as only the correct key fits a lock. Only the correct ligand fits the receptor. The receptor. So, first of all, that ligand approaches the receptor, then this ligand binds to the receptor, and this ligand and receptor that will form a complex, and the cell response or pharmacological actions will happen. So, examples of response such as muscle contraction, body fluid secretion, pain relief, decrease in blood pressure, etc. So types of this drug action or in this model is agonistic action. Agonistic means what? It is a drug that binds to a receptor and activate it to produce a response. So the mechanism means that will mimic the a natural ligand and that will open the lobe and produce the biological effect. Example, salbutamol, morphine, etc. Salbutamol means it is a beta 2 receptor antagonist, and morphine is an opioid agonist. Adrenaline is an adrenergic agonist. So, agonist on switch or means on switching upon this agonistic activity. Antagonist means definition means that it will opposite to the agonistic. That means a drug that binds to the receptor but it does not activate it. That means it occupies the receptor and block the natural ligand and prevent the response. That means atropine. When using atropine, muscarinic antagonistic and propranolol it is a beta blocker and naloxone it is an opioid antagonist. So here antagonist means it off or block the action. Agonist means switch on or on the action. So here you can see an image. It's a natural hormone or neurotransmitter that fits the receptor. So response produced. And the second middle figure, a agonist drug fit the receptor. So same response is produced. And last figure, bottom figure, an agonist bind to the receptor, block the natural ligand, and there should not be any kind of responses occur. So what are the characteristics of this lock and key model? It having high specificity, selective binding, and high specificity, selective binding, and explain many drug actions, and it is used in pharmacology. So, the main limitation of the lock and key model. The, actually, it is very useful method, and it is also useful. It is oversimplified because receptors are flexible. It is not rigid. Shape may change after binding, and some drug partially activate the receptor. So, better explained by the induced feed model. So, coming to the clinical importance of this lock and key model, the understanding the receptor interaction helps in the drug design, drug selectivity, reducing side effect, choosing an agonistic or antagonistic in therapy, and quick comparison table. When coming to quick comparison table, here they feature agonistic or antagonistic binding receptor. That means it activated. So, upon studying this locality method model, you are ready to answer this kind of questions. That is, means what is locality model? What is locality model? Actually, what locality model state that's only specific ligand fits to a specific receptor to produce an action. Agonistic means a drug that binds to a receptor and is producing a pharmacological action. Antagonistic means that it binds to the receptor, but it does not provide any kind of pharmacological action. So this is a lock and key method or lock and key model of a receptor ligand interaction. So here what is lock and what is key? So what is lock and what is key? Key means ligand, lock means receptor. Only a ligand with the correct shape, size and chemical properties can bind to a specific receptor and produce an effect. So, when two drugs are binding to the same receptor at the same site, why it is that one is acting as an agonist while other is serving as an antagonist? So, when two drugs are binding to the same receptor and at the same site, why it is that one is acting as an agonist, while other is serving as an antagonist. So, so this is a classic pharmacological question. That means two drugs may bind to the same receptor and even the same binding site, but they can produce a different effect because binding alone is not enough to produce a pharmacological action. So the key difference is agonist that will bind and activate the receptor, antagonist that will bind but does not activate the receptor. So the issue is not just where they bind, but what happens after binding. So here is the affinity versus efficacy. That's the difference. What is maybe affinity? Affinity means ability of the drug that binding to a receptor. Efficacy means intrinsic activity. That means the ability of the drug binding to the receptor and to produce or activate the receptor and produce a pharmacological action or produce a produce a response. So agonist means that having affinity and efficacy. Antagonist means that having affinity but no efficacy. So receptor means it's like a locked door. It's a door lock. Agonist correct key that will open the door. Antagonist key that fits inside but cannot turn the lock. Both fit the same locker but only one can open it. So that is the difference. So when coming to this kind of questions from molecular explanation, that means when a drug binds to a receptor, it may cause a conformational change. That means a shape change may occur in the receptor. The receptor agonist, if it is agonist, then will stabilize the active form of the receptor and trigger the signal transduction and produce the cellular response. Antagonist is it is antagonist that will occupies the receptor without activating it, prevent the agonist binding and no signals generated. Receptor state concept means when the receptor exists in two forms, inactive state and active state. Agonist means that it prefers and stimulates the uh, active state. Antagonist means that it bind equally or neutrally, does not shift the receptor to active the active state. So this is why same binding can give different outcomes. Another example, another reason, if two drugs bind the same pocket, same receptor, their shape may differ. Their chemical groups may differ. Bonding interaction differ. Orientation inside the receptor differs. These differences determine whether receptor activate or stay silent. For example, beta adrenoreceptors. Agonistal mean is a salbutamol. This salbutamol will bind to the beta 2 receptor and activate the receptor. So what happened? Bronchodilation occurs. Antagonist means a propranolol that will bind the same receptor and block adrenaline or salbutamol. No bronchodilation. Next step, opioid receptor that is agonistic and agonistic means morphine drug that will activate the receptor. Analgesia occur and antagonistic drug of the morphine is a naloxone. So the naloxone also that will bind to the same receptor that reverses the opioid overdose or that will reverse the action of morphine. And next is the competitive antagonism. When agonist or antagonist compete for the same site, both the drugs for compete with the same site, higher agonistic concentration can overcome the antagonistic effect. That means for reversible competitive antagonist. This is called competitive antagonism. Next, concept of dual nature of the receptor. So this receptor having dual nature. One having active state, another is in inactive state. So if RA means active state, RI means inactive state. If RA and RI conformations are in equilibrium, the extent to which this equilibrium perturbed shall be determined by the relative affinity of the drug for these two conformations. So, the modern receptor theory explains that receptors are not a fixed structure. It is not a fixed structure. Then it can exist in two different conformational states and continuously shift between them. This is called a dual nature receptors. So, there is no fixed structure. There is no fixed shape. They can exist in two different conformational states and continuously fit the shift between them. two conformations of receptor are a receptor that is usually exists in equilibrium between an active state. That is a functional form of receptor is the active state of RA. That means they are capable of producing signal and activate the secondary messenger system and lead to the biological response, etc. In, then in an inactive state means that a resting form of a receptor is known as inactive state RI. It does not produce any kind of signal, no cellular response occur, and dynamic equilibrium. So the receptor continuously move between the RA and RI. Dynamic equilibrium means a receptor continuously moving between the active state and inactive state. That means RA and RI. This means even without any drugs, the receptor naturally fluctuates between the active and the inactive state. So there will be a fluctuation occur between the active and inactive states. So some receptor may show basal activity. Some receptor may show basal activity due to the small number being in an active state. So the role of dynamics or the role of drug in this equilibrium is drug do not simply switch on or switch off the receptor. They shift the equilibrium toward one state depending on which conformation they prefer. So type of the drugs based on the receptor preference. Agonist uh, has higher affinity for RA, stabilize the active state and shift equilibrium toward the activation. RI to RA. That means increase the receptor response. For example, salbutamol, adrenaline, morphine, etc. Second one is antagonist action that will bind receptor but has equal affinity for RA and RI or no preference. Does not alter equilibrium significantly. So result is no activation but block the agonistic binding. For example, the antagonistic action is atropine, propranolol, naloxone, etc. Next, inverse agonist. It has a higher affinity for RI, stabilize the inactive state, and shift the equilibrium toward the inactivation. RI leads to RI that results in the reduced basal receptor activity. Some antihistamine, beta carbolines, etc. That reduces the basal receptor activity. And why this theory is important? So why this theory is important? That means older lock and key theory could not explain the basic receptor activity. Sorry, basal receptor activity. That means the older lock and key method it should not explain about the basal receptor activity, inverse agonism, inverse agonism, partial agonism, constantly active receptors. So the two-state model or the dual nature concept that will explain all these phenomena. Partial agonist എന്താണെന്നും that is extra concept. That means a partial agonist is a binds to the receptor but produces less activation than a full agonist because it only partially shifts the equilibrium towards the RA. That means, for example, buprenorphine or pindalone. So, um, so that's all about the concept of a dual nature of the receptor. Next, two terms agonist and antagonist. Agonist means drugs having high affinity for the active conformation RA than for the inactive RI. Antagonist means these drugs bind to the either of these conformation RA or RI with equal affinity. It will not shift the equilibrium to any side. Agonist means so agonist and antagonist. Agonist means a receptor drug having high affinity and active conformation and that will produce a pharmacological action. Antagonist means this drug binded to this conformation. That means they will bind to the receptor but does not produce any kind of pharmacology. That means antagonist is the just opposite that of a agonist. Next, partial agonist. So these have a slightly higher affinity for RA than for the RI, and hence the shift the equilibrium toward RA to the lesser extent than a true agonist. So such drugs therefore display an intermediate effectiveness between the agonistic and antagonistic action. So next, constitute receptor activation. So in this picture you can see PR R. R means inactive state, DR active state, and biological effect occurs plus agonist and spontaneous action. So agonist, for example, drug, hormone, neurotransmitter. That binding induces a conformation change in the receptor from the inactive to active state. When agonist bind to a receptor, there should be a conformation change in the receptor from inactive state to the active state. So the conformation changes to active state can occur also occur spontaneously in the absence of agonist. So in the absence of agonist, when there is no agonist, they can now then also a conformation changes occur on this receptor or to the active state that can also produce spontaneously. That is a random kinetic fluctuations. And agonist dramatically increases the probability of a conformational changes and stabilizes the active state. So the constitutive receptor activation means some receptors that can become active even in the absence of any ligand. So some receptor can become active, and even in the absence of any ligand, they can produce the drug. They can produce the actions. For example, for drug, hormone, and neurotransmitter, uh, they can become active in the absence of any ligand. So this phenomenon is called a constitutive receptor activation or constitutive activity. That means some receptor that can become active either in the absence of any kind of ligand, any drug, hormone or neurotransmitter. Without anything, some receptor can become active, and that phenomenon is called as constitutive receptor activation or constitutive activity. So it means the receptor has an inherent ability to switch into an active form and generate a response spontaneously. So the basic concept of this receptor constitutive receptor activation are the receptors are not always completely off. They exist in equilibrium between inactive and active receptor state. So even without any agonist, a small proportion of the receptor may spontaneously convert R to RA. So, this kind of spontaneous activation can produce a basal biological effect. For example, what happens when an agonist binds? When an agonist increases the probability of receptor entering the active state and stabilize the active form. That means R plus agonist, they will produce response, and more receptor become active, their signal transduction stronger and increase the biological response. So in here the left side shows in the inactive receptor and the center portion two-way receptor become active. Spontaneous activation. That means the receptor naturally changes to the active form. Agonist induced activation. Agonist bind receptor and promote the active state. And the right side you can see the biological active form lead to the biological effect. That means cellular effective response may occur. And why does it happen? So the constitutive activity occur due to the natural flexibility of the receptor protein and random molecular function and intrinsic receptor dynamics, genetic mutations, and overexpression of the receptor. Then next, another point is a neutral antagonist. Neutral antagonist means bind receptor but does not change the basal activity and only block the agonistic effect. So neutral antagonist means that will bind the receptor, the drug will bind the receptor but does not change the basal activity and only block the agonistic effect. Required effectiveness മാത്രം block ചെയ്യും. So there is no decrease in the constitutive activity. And inverse agonist, as we already discussed, that will reduce the constitutive activity below the basal level. For example, many drugs, histamines, antihistamines, that act as a inverse agonist. So the constitutive action is important in a drug development. That means help distinguish the antagonist versus inverse agonist. And in disease stage, the mutated the receptor may remain permanently active. Example, hyperthyroidism, TSH mutation, receptor mutation, certain cancer, endocrine disorders, etc. And then pharmacological research that used in the receptor signaling studies. Next, inverse agonist. There are certain receptors which remain inherently in the RA state even in the absence of an endogenous ligand or an exogenous agonist. So, inverse agonist inactivates such a constitutively active receptor and therefore prevents its basal activity. So, as a result, inverse agonist produces an effect opposite to that of an agonist or a drug. So, inverse agonist review the constitutive receptor therapy. So, agonist has an independent impact upon the receptor activity. Antagonist impact receptor activity only in the presence of agonist. The inverse agonist has an independent impact upon the receptor activity and produce an effect opposite to the agonist. So that is the agonist, antagonist, and inverse agonist. Receptor types, ion channel receptors. So there are mainly kinds of receptors are there. First one is ion channel receptors. Ion channel receptors is otherwise known as ionotropic receptor. And G protein coupled receptor, it is known as metabotropic receptor. Kinase linked receptor, it is known as, the next one is the intracellular receptor, it is known as a cytosolic receptor. And the fifth one, enzymes. And sixth one, drug which acts through modulation of voltage gated ion channels, voltage gated receptors. So these are the main six types of receptor, which are the ion channel, G protein coupled, kinase linked, intracellular receptor, enzyme, uh, modulation of voltage gated ion channel receptor. So here in this diagram we can see the ligand gated ion channels receptor, ionotropic receptor. Second one is protein, G protein coupled receptor, kinase link receptor, and nuclear receptor. So, receptors are the specialized proteins that recognize the drug, hormones, or neurotransmitter, and these that will convert binding into a biological response. So, based on structure and signaling mechanism, receptors are mainly divided into four major types: ligand gated, G protein coupled, kinase linked, and nuclear receptor. These are the main four kind of receptor: ligand gated ion channel, G protein coupled receptor or GPCRS, kinase linked receptor, and nuclear receptor. Ligand gated ion channels. These are the, it is a first one, ligand gated ion channels or ionotropic receptors. These are the membrane receptor that contain an ion channel. So when a ligand binds, the channel opens or closes and allowing the ion to move across the membrane. So here the ligand gated ion channels mechanism is when ligand binds the receptor, channel will open and ion flow changes membrane potential. When the membrane potential changes, that may leading to the cellular response. So the ions involved are Na plus, K plus, Ca2 plus, Cl minus. So what will happen? Effects are depolarization may occur, hyperdepolarization, rapid synaptic transmission, time scale changes, milliseconds. That is very fast. So nicotinic acetylcholine receptor examples, GABA A receptor example, NMDA receptor. So the ligand-gated ion channels uses means they target for the anesthetics, sedative, muscle relaxant drugs. So it is a target for the, so this ligand-gated ion is a target for specific types of drugs such as anesthetics, sedatives, muscle relaxant, etc. Second one is a G protein coupled receptor or metabotropic receptor. So these receptors are linked to the G protein and activate the second messenger system. That means a single polypeptide, and it is a seven transmembrane domains. The mechanism of these receptors are the ligand bind the receptor, G protein get activated, effector enzyme or ion channel activated, and leading to the release of secondary messenger compounds. A response may produce. So, a secondary messengers will produce. So, the examples of the or common secondary messengers are cyclic AMP, inositol triphosphate, diacylglycerol, calcium, etc. Calcium is responsible for the contractions. So, effect means changes in excitability, enzyme activation, secretion, smooth muscle contraction or relaxation, and time scale, etc. So, what is the clinical importance of these receptors? So, largest drug target family, kinase linked receptors are the largest drug target family. So when coming to the kinase link receptor, these receptors possess a intrinsic enzyme activity or are associated with the kinases. So usually involved in growth, metabolism, cell regulation, etc. So the ligand will bind to the receptor dimerization occurs, phosphorylation occurs, signal cascade occurs, gene transcription or protein synthesis. So the common types are receptor tyrosine kinase, cytokine receptor, JAK-STAT pathway. Effects are cell growth occur, differentiation, metabolism, immune response, time scale, etc. For the examples of these are epidermal growth factor receptor, EGFR, cytokine receptor. So it is important in the diabetes and cancer therapy. Next, ion channels. These are the localized to the cell membrane, and this ion channels are coupled directly to an ion channel. So it's a channel within receptor site. Agonist opens the channels, and antagonist prevent the agonist from opening the channel. So inverse agonist closes and open the channel. So ion channel means it is located on the cell membrane. So agonist drug will bind, open the channel, and antagonists will prevent the opening of the channel. So multiple subunit proteins which form a cation or anion channels. So the channel properties are determined by the composition of a subunit isoforms such as agonistic affinity, ion permeabilities, conductance properties, activation and deactivation time, desensitization kinetics, etc. The activities can be regulated by this changes in the different composition of the different subunits. So the major two families are nicotinic family and glutamate receptor family. Nicotinic family include acetylcholine receptor, GABA A and GABA C, glycine receptor, and 5-HT3 receptors, etc. Glutamate receptor family, it's several different receptor types classified into NMDA receptor and non-NMDA receptor. NMDA means it is the receptor for the excitatory neurotransmitter. So this is the diagram of the ligand gain ion channels. These are the receptors that act as ion channels. When a ligand, that means a drug or neurotransmitter bind, this channel open or closes, allowing ion to move through the receptor membrane. They produce a rapid response. That means it produces rapid response in milliseconds. For example, acetylcholine, nicotinic acetylcholine receptor, GABA A receptor, glycine receptor. So the figure has three portions, parts A, B, and C. A means agonist will bind to the receptor. The channel opens. The agonist binds the receptor. Channel opens. The ion passes through the receptor, and then leading to the depolarization or hyperpolarization, which lead to the cellular effect. The depolarization means the inside of the cell become less negative and usually caused by sodium influx, calcium influx, etc. And that may leading to the excitation. Hyperpolarization inside become more negative and it is usually caused by Cl minus influx, K plus influx and leading to the inhibition. And in the second diagram B, channel channel blocker prevent ion entry mechanism. So the agonist may bind the receptor but blocker block the ion pore and ions cannot pass. So that may leading no cellular response. So this is called a channel blockade. The local anesthetic blocks, for example, local anesthetics blocks the sodium channels, picrotoxin blocks the GABA A chloride channel, etc. And the Z portion, nicotinic acetylcholine receptor, this part shows a nicotinic receptor structure. So it having five structures subunit, two alpha subunit, one beta and one gamma subunit are there. So the channel closed state without acetylcholine, this channel remains closed, so there is no ion movement. So the channel open state when two molecules of acetylcholine binding to the alpha subunit and this receptor changes the shape and central pores open, mainly sodium ion center that may leading to the depolarization, and this causes the muscle contraction or nerve transmission. Next, G protein coupled receptors. So these are the composed of seven transmembrane helix structure and it having an extracellular domain as well as it having intracellular domain. So extracellular domain is a drug or neurotransmitter and binding site, and an intracellular domain that couples to a G protein. It is a protein molecule. So this is an image. It is a cleavage by thrombin. It is an inactive state, and when it is cleaved by thrombin, they may be leading to an active state, and the fragment is released, mainly undergoing phosphorylation, and it is undergoing desensitization. So this is the diagram that showing the activation cycle of a G protein coupled receptor. How it activates the intracellular target proteins. So the GPCR is the membrane receptor that transmit. So the GPCR are the membrane receptor that transmit the signal from outside the cell to inside the cell through a G protein. So they are involved in the hormone action, neurotransmission, sensory responses, cardiac regulation, smooth muscle contraction, etc. So here the components in the diagram. First one is the receptor that present on the cell membrane and bind the agonist, that means the drug or ligand. Second component is the G protein. It is made up of three subunits, alpha, beta and gamma. So in inactive state, alpha bound to the GDP. And third component is a target protein. Example for the target proteins are adenyl cyclase, phospholipase C, ion channels, etc. So first one, resting state. That is top left, resting state. The receptor is free, there is no agonist bound, and the G protein attached to the inner membrane, and the alpha subunit contain the GDP. So, alpha, beta, gamma remain together. The target proteins are inactive. So, there is no signal transmission occur. And the second, the receptor occupied by the agonist, that is top right, occupied by the agonist. The receptor changes the shape, that means the conformational changes occur, activate the receptor, and that may interact with the G protein. So here, GDP that leaves the alpha subunit and GTP binds. So GDP is converted to the GTP, and that portion, the target protein activated, bottom portion, right side. So the target protein activated alpha GTP separate from beta gamma complex, and the both part can activate target protein. For example, alpha activate adenyl cyclase, beta gamma open in ion channels, and now signal is transmitted inside the cell. And fourth portion, component GTP hydrolyzed, bottom left side, alpha subunit has an intrinsic GTPase activity, and that may convert GTP to GDP, and alpha become inactive again. Alpha reunite with the beta gamma, and system returns to the resting state. So the full cycle explains that a GDP it is replaced by GTP, alpha separated from a beta gamma, and target protein activated, GTP hydrolyzed, and G protein are reassociated. So here main things or the important terms to remember is the agonist. Agonist means a substance that activates receptor. GDP, it is inactive. Guanosine diphosphate. GTP, active guanosine triphosphate. Intrinsic GTP is that having the ability of alpha subunit to break the GTP. The pharmacological importance of these are many drugs act through GPCR, The drug receptors such as salbutamol, beta 2 receptor, propranolol, beta receptor that will block the receptor blocker, and atropine muscarinic blocker, morphine opioid receptor, etc. So the types of the protein receptors, the type of gamma subunit. Type action GS stimulate adenyl cyclase and increases the cyclic AMP and inhibit the adenyl cyclase level and decreases the cyclic AMP and GQ activate and then PLC is converted into IP3 and DAG. IP3 means inositol triphosphate and DAG means diacylglycerol. So why do GPCRs are not act directly on the effector means of amplify signal? The G proteins can act as integrators of input from several stimuli, and G protein can regulate more than one effector, that is divergence. And G protein can act integrators of input from several stimuli is known as a convergence. So here the conversion of an extracellular signal into the cellular response. Here a ligand or drug bind to a receptor and start a chain of event inside the cell. So this process is essential for the hormone action, neurotransmission, growth regulation, metabolism, immune responses, etc. So the main component of the diagram is the ligand or first messenger, that is a chemical signal outside from the cell. For example, hormones, neurotransmitter, drugs, etc. Second is the receptor, protein on the cell membrane inside the cell, recognize the ligand specifically. And third portion is the G protein or coupling protein that transfers signal from the receptor to the effector. Effectors are the enzymes or channel activated by the receptor system. Adenyl, for example, adenyl cyclase, phospholipase, ion channels, etc. And fifth one is next is the secondary messengers. There is small intracellular molecules are there that carry the signal. For example, CAMB, CGMB, IP3, DAG, CA2 plus, etc. So here first step is the ligand bind receptor attached to the receptor. Receptor change the shape and become activated. Second is the activation of G protein. Activated receptor stimulate the G protein. G protein carries the signal to the effector enzyme. Step 3, effector activation. Effector enzyme become active, produce the secondary messengers. And fourth step is the second messenger formation. Second messengers spread rapidly in cytoplasm and activate downstream protein. They help amplify the signal. And step 5, protein kinase activation. Secondary messengers activate kinase such as protein kinase A, C, etc. So three main variants of GPCRs. GS means stimulation of adenyl cyclase. GI means inhibition of adenyl cyclase. GQ means controlled phospholipase C activates. And G protein coupled effector system, adenyl cyclase EMB system, phospholipase C inositol phosphate system, and ion channels. So this is the adenyl cyclase AMP system. So here the 5 AMP cyclic AMP produces and the adenyl cyclase activate and may lead to the protein kinase inactivation. Phosphorylation occur, protein kinase may activate it. So the protein kinase activation may leading to the calcium release, lipolysis increases, glycogen synthesis decreases. Next, kinase linked receptor. So these receptors are directly linked to the tyrosine kinase. Example receptors for insulin and various tissue growth factors or guanylate cyclase. Example receptor for atrial or natriuretic. Intracellular receptors are this nuclear receptor family senses the signal from the lipid soluble substance and other hormonal substance to influence the gene expression. Next, drug plus target. Drug rapidly occurring, the rapid physiological response occurs and alter the gene expression and may leading to the response, delayed responses. So, enzymes act as a receptor. So, drugs can either mimic the enzyme substrate or may bind to its allosteric site to produce the effect. Example, angiotensin converting enzyme and acetylcholinesterase enzyme. And other one is the voltage operated channels. They are the only having as only two states, open or closed, and the third state is called refractory, that means inactivated state. Refractory state means it is unable to open or reactivate for a certain period of time, even when the membrane potential returns to a voltage that normally opens or activate the channel. Next, drug desensitization. So, this diagram, receptor mediated desensitization, where is a response of the drug decreases when it is given continuously or repeated administration causes the decreased response. So, the drug desensitization means a progressive reduction biological response after repeated or continuous exposure to a drug. So, initially, the drug gave a strong effect, but later the same dose produces a less effect. The graphical explanation, x-axis here it is time and y-axis biological effect. So at the first high response is high, gradually decreases with the time. Eventually, very little responses remains. So the body becomes less responsive to the drug, and that term is related to the desensitization. That means reduced receptor responsiveness after the continuous administration or continuous stimulation. Tachyphylaxis means a very rapid loss of response after repeated doses in short time. Refractoriness means temporary responsiveness to the drug, and resistance occurs that the drug remains become ineffective and often used in antimicrobial or cancer therapy. And fifth one is tolerance. That means need higher dose to produce the same effect. There are two types of mechanism: receptor mediated and non-receptor mediated. Receptor mediated means that involves changes in the receptor. That means loss of receptor function, but does not produce the response properly, and that may lead into the phosphorylation, uncoupling of G protein, conformation changes, etc. And second one is the reduction of receptor number, down regulation. Number of receptors decreased. These are the main kind of actions. And reduction of a receptor coupled signaling components, G protein reduced, secondary messengers reduced, effectors enzyme less active. So there is signal pathway become weak. So reduction of drug concentration may causes the drug level decreases due to the faster metabolism, increased excretion, enzyme induction. For example, barbiturate tolerance. Physiological adaptation. Body opposes drug action through the compensatory changes. That's all about the receptor mediated desensitization. Next, non-receptor mediated desensitization. First one is the reduction of receptor coupled signaling component. Second one is the increased metabolic degradation. Third one is the physiological adaptation. So, first one is reduction of receptor coupled signaling component. Depletion of the signaling molecules that required for the biological response. Example, prolonged stimulation of G protein coupled receptor can lead to depletion of the intracellular secretory messenger. And increased metabolic degradation causes the increase in the rate of metabolism and or the elimination of the drug, lower the plasma drug concentration. Physiological adaptation, reduction or amelioration of the drug effect due to the opposing homeostasis response. Next is the down regulation. Prolonged exposure to the higher concentration of agonist causes a reduction in the number receptor available for activation, and this results due to the endocytosis or internalization of the receptor from the cell surface. The upregulation of receptor, prolonged occupation of receptor by a blocker lead to the increase in the number of receptors. If number of receptors increasing, upregulation; number of receptors decreasing, downregulation. So this is due to the externalization of the receptor from inside of the cell surface. Next is the spare receptors. So a drug can produce the maximum response even when even less than 100% of the receptors are occupied. The remaining unoccupied receptors are just serving as a receptor reserve are called spare receptors. Spare receptor means a spare one, extra, or the unoccupied remaining receptors are known as spare receptors. The receptor-related disease, myasthenia gravis, insulin-resistant disease, testicular feminization, familial hypercholesteremia, etc. So, it's coming to an end. The receptor pharmacology actually it is the foundation for understanding how drug produce their effect in the body or drug interact with a specific receptor as antagonist, agonist, partial agonist, inverse agonist to initiate or block the cellular receptor responses. So the receptor activation trigger the signaling pathways such as ion channel opening, G protein activation, enzyme regulation, and second messenger cascades. Factors like affinity, efficacy, selectivity, regulation, desensitization, and tolerance influence the magnitude and duration of drug action. Therefore, knowledge of receptor pharmacology is essential for rational drug design, safe therapeutic use, and the development of a newer targeted medicine. So that's all about the receptor pharmacology. Thank you so much.